Good afternoon, and welcome to today's program titled, How Surgical Documentation Workflows Impact Your Revenue Cycle Improvement Strategy. My name is Jeff Connick, and I will be your moderator for today's event. Our program today will be 60 minutes in length. The first portion of the program is a presentation, followed by a question and answer session. Note that an on-demand version of this program will be available approximately 24 hours after the completion of the event today, and can be accessed using the same login link that you use for today's live program. Today's program is sponsored by Nuance. Thank you to our sponsor and to you and our audience for giving us your time and attention. Before we get started, I just have a few housekeeping details I'd like to run through. First, to ensure that you can see all of the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Second, you will find a resources list for today's webinar in the lower left of your screen. Here, we have listed the webinar slide deck and additional resources for you to interact with during the program. Third, at the bottom of your console are multiple widgets you can use during the program. To submit a question, click on the Q&A widget. It may already be open and appear in the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Should you experience any technical difficulties during today's program and need assistance, please feel free to click on the yellow Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our speakers for today's event. Mercedes Dullum, MD, FACS, FACC, who is the Regional Medical Director for Nuance, Lucian Newman III, MD, FACS, Chief Medical Officer and Founder of Vincari, and Benjamin Diddy, MD, Neurosurgery and Spinal Surgery. Thank you all for participating with us today, and with that, I'd like to hand the audience over to you.
Thank you, Jeff. Hi, I'm Mercedes Dullum. I'm one of the Regional Medical Directors for Nuance Healthcare. I'm a cardiac surgeon by training and practice, and as you all know, we have been very involved in quality and outcomes from the inception. I have had the honor and privilege of working with Nuance Communications on our clinical documentation improvement, surgical notes and improvement, and throughout our practice, we have tried to improve our documentation to make sure that we capture everything on severity. I have with me today our two experts, Dr. Lucian Newman, who is the founder of this very elegant software solution to our documentation, and Dr. Benjamin Diddy, neurosurgeon, spinal surgery. I'm going to hand it over to Dr. Newman to introduce himself, and then Dr. Diddy. Thank you for being here with us today. Dr. Newman.
Great. It's great to be here today. And as Dr. Dullum was mentioning, I'm a general surgeon specializing in minimally invasive surgery. And my family goes back in medicine in Alabama 122 years. I currently serve as chair of the Blue Cross Blue Shield Physicians Advisory Board, and I've served in numerous other positions. However, about 15 years ago, my sense is that we needed to add order to a disorderly process. And dictating procedure notes includes quite a number of perils and pitfalls. If you don't have guidance, you really aren't improving things as you go along. And actually, we fancy ourselves surgeons. We fancy ourselves as creating artwork in surgery, such as the Mona Lisa, and then what we're handing off in terms of documentation is a crayon drawing out of the second grade. So I'd like to start also by introducing Dr. Diddy, who is a surgeon who learned about this system. Dr. Diddy.
Yeah, hi, my name is Ben Diddy. I'm a neurosurgeon in North Carolina in transition to Florida. Good to be with you all today. I first encountered Vincari when it was under a different name. It was called ComplyMD, and it was used by our cerebrovascular surgeon in my training program. And I always thought that it was an incredibly elegant way to capture the procedures that we were doing, and it was incredibly repeatable, and it made sure that it answered all of the questions. So I look forward to talking with you today to give you my experience, how I implemented it into my practice, and what I see with it going forward.
Thank you, Ben. We're going to kind of get into the meat of our program now, and as you'll see, we do have some polling questions, and at the end, the Q&A. And we do have a prepared presentation for you, but we're very interested in getting feedback, getting questions from you at the completion of our presentation on what issues you're facing and how this solution might actually work for you. So as we all know, provider burnout is a very important aspect now. Everybody's talking about it. It's kind of like the hot topic. But in fact, it is a serious issue. You know, it causes a lot of cost. There's 40% of the time, at least, in documenting, over 4,000 clicks in a day and 7.2 million words by one single provider. And that's a lot of time spent away from the patient care, away from your operation, and away from taking care of running your practice. Healthcare costs, as we all know, continue to soar. 64% of improper payments are due to insufficient documentation, and 90% of these details are preventable. And when we get denials, you'll see that the main reason that we actually get denied for a procedure is our documentation to begin with wasn't right. And then when we get queried on it, we don't answer it, or we answer it in a very quick fashion, really not paying attention to the details. Also, the problem with documentation is that this affects the quality of care that we provide. Provider reputations, the brand is impacted, and there's suboptimal leverage in payer negotiations. And we'll get into this a little bit more, and Dr. Newman, like I said, is the expert and the innovator in this area. But this affects the physician practice, their profile. One of the big parts that I do with Nuance is our clinical documentation improvement program, lecturing to hospitals throughout the country, to physicians and providers of all walks of life. And this is a really big issue, how this affects our quality, the publicly reported data. And then, of course, there's a patient experience at the end. The fact that you can't spend the time with your patients because you're having to get all the paperwork done does affect how your patients perceive the care that they received. And then they really want your undivided attention. Think about it. That's what we're here for. We all went into medicine to take care of patients. So we all know the problem, and we have the solution. So like I mentioned, we do have some polling questions. And here's the first one. And the way this is, it says, our hospital never has an issue with appropriate CPT coding by the surgeons. If I could hear you guys, I would imagine you'd be laughing on this question. So, but this is a serious issue. And the reason that, and we're very interested in your answer. So when you click your answer to this, we'll see it on the next slide. We'll show what's actually going on at your sites. It'll be aggregate. But, you know, one of the reasons that it's the inappropriate coding is because it's not supported by documentation. So I think we've had enough time. I'm going to move on so we can see what your answers are. So there you go. This is the problem that we all have. So the majority of us at all sites and with our listeners today and participants seem. So let's go on to our next slide. So why is accurate surgical documentation so important? As I mentioned before in our previous slides, this affects both our practice, our physician profiles, the specificity of what we're doing, the severity of what we're doing, and in the end will actually affect our ability to practice. So not only quality of care, but also our practice. I'm going to turn it over to Dr. Newman now to carry on.
Great.
Dr. Newman?
So as we know, surgeons are reimbursed for what they do via CPT code. Obviously, the hospitals use ICD codes likewise to record what's done and why it's done. And so I would like to mention that, you know, the much maligned ICD process actually dates back several hundred years, and it had quite noble origins. In the mid-1700s, we were first classifying diseases that killed people, trying to figure out what we could do about that. And then in the late 1800s or mid 1800s in England, they published the first London Bills of Mortality to study things like rickets and thrush and smallpox and trauma. And then in around 1900, 1899, the first international list of causes of death was published. And it wasn't until 1948 when the sixth revision came about and added morbidity. So while we can all take a chuckle at what happened with ICD-10, the reality is that it had very noble intent. And so let's look at CPT coding. And so the way a physician actually gets reimbursed for what they do, is not mysterious. It's actually right there in front of you. And the conversion factor is what changes every year based on funds available. And so the other components, or the component that the physician can impact on a day-to-day basis, is the work RVU. And so if you look at the other components, there's a practice expense RVU, a malpractice insurance expense, and of course the geography issue, so that a surgeon that does a procedure in New York will get paid more than I do in Alabama. So the list of CPT variations is virtually endless, it seems like. And the problem is that most surgeons, well, let's just say this, no surgeon goes through CPT training in their residency. We learn how to take care of patients. We learn how to do procedures safely. And nobody is asked to focus on the coding issues. And when in reality, our very livelihood relies on that. And it's not just our livelihood, it's the livelihood of the hospitals where we work. And so physicians and surgeons who are ill prepared to do this run into problems. And so this slide just shows you, for example, a hysterectomy. You may do that procedure open versus laparoscopic. It may be a total, it may be a supracervical. It could be with or without salpingo-oophorectomy. And so, you can go through each procedure, thyroid, pericardial interventions, prostatectomy. And the reality is there's a lot of different CPT variations, and it's very easy not to get the right verbiage in there so that your coding professionals behind you don't know the answer. And so just hernias. Hernias are a common operation that I do. And yet, if you forget to say recurrent hernia, there's a impact on your CPT coding. If you for example, forget to say mesh, and you can all think to yourselves, oh, there's no way they would forget to say that. But I'm telling you, that's not true. And so I mentioned earlier that this was created primarily to add order to a disorderly process. And so, in my opinion, the guidance that is provided while you're doing your procedures or recording your procedures is very, very helpful. And so nephrectomy, a common procedure where a kidney's removed. You can see the RVU values out to the right there. And, dramatic differences in the reimbursement to the physician, but also it adds the level of complexity to the hospital recording. And so one of my favorite slides is actually public scorecards. And so whether we like it or not, when we surf the internet and we look for hotels, we're checking their star status and see how many 4-star hotels you can get for $200 or whatever. The same thing's happening to physicians. This is an actual scorecard that was published. And so what you see is that you have surgeons on the left and hospitals in the middle, and then you can see labels of the worst surgeons in California. Well, that's not actually true. What's actually true is that these surgeons have a high risk-adjusted mortality rate. So if you did a little exercise and said, well, I have a surgeon that does 100 bypasses and 10 patients die, or another surgeon that does 20 and 2 die, you would say, well, they're obviously the same with a 10% mortality rate. It's not really true, because if the busier surgeon had a much higher severity of illness and recorded these and documented this, his actual recorded adjusted mortality rate is much lower. And so as we go forward, data analytics becomes increasingly important. And so not having some order to the process is a mistake in my opinion. So Mercedes, you want to comment on thoracoscopy here?
Yeah, thank you, Lucian. And actually, I'm sorry I didn't give you a chance back at our polling question about our hospital not having with the appropriate CPT coding by surgeons. I know in your other position with Blue Cross Blue Shield, you see a lot of this, and I was wondering if you had any comments on this, or Dr. Diddy with the CPT coding by surgeons. Okay.
Well, sure. And just as we know the public is going to start seeing the data, or they already are, they actually have been for some time, the reality is that every hospital, every IDN, every hospital corporation, Medicare, Blue Cross, all of them review spreadsheets to try to see how the performance of their surgeons looks. And they actually reimburse hospitals differently based on those results. And so failure to understand that process, it costs the hospitals and surgeons financially, but more importantly, it costs them reputationally. And so, you know, these things are occurring. They are being reviewed in every hospital in every state. Dr. Diddy?
Yeah, I completely agree. And just to echo what Dr. Newman mentioned earlier, surgeons these days have no training in CPT coding and appropriate documentation. I spent 7 years in residency, learned to do complex cases, cerebrovascular and spinal cases. I never at one point learned anything about appropriate CPT coding or the verbiage that needed to be included to capture the complexity of cases. And so when I started practice, I was entirely underprepared for that. But with the use of Vincari, I was able to actually learn that piece. Even though it took care of it for me, I was able to look at the output and understand these critical pieces of the documentation game so that I could take it to the other hospitals where I didn't have access to Vincari. And so it really did make me a more well-rounded documenter and help me capture the complexity of my cases so that I could make sure that I was given credit for the complex cases and not given too much credit when it was inappropriate.
Thank you, Dr. Diddy. Yeah, and you have, like you said, very complex procedures. Well, as I mentioned, I'm a cardiac surgeon, and if you can look at something as simple as a thoracoscopy, because most of our work now is done endoscopically, regardless of what your specialty is. Many of our regular cases, I would say, your bread and butter. But if you take something simple as whether it was a therapeutic or a diagnostic procedure, and this is something very easy for coders to miss if we don't have the responsibility of documenting it appropriately. And if you look, one word change will make a huge difference. These are just for example purposes, but from the hospital reimbursement on your appropriate DRG, you can see the big difference between a diagnostic procedure or therapeutic, and also from the professional reimbursement impact. It impacts it greater than 2 times. So we have to be sure, even though we know that CMS says that it is the coder's responsibility to accurately code a surgical procedure, as surgeons, we cannot abdicate our responsibility for doing this appropriately. And as a hospital system, I think we need to hold surgeons accountable for this, give them the tools to be able to do this appropriately. So let's, there was our other example to drill down a little bit more. If we look at our appendectomy with peritonitis, this is something that Dr. Newman deals with a great deal, so I'll let him discuss this in more detail for you.
Sure. So, and this is perhaps one of my favorite examples just because of something Mercedes just mentioned, which is the concept of one word. And so if you think that if I do an appendix at 11 o'clock at night and I'm sharp with my dictations as I was 20 years ago, that just wasn't the case. And so typically we would default to the most common or the fastest way to document, and I might just say the words acute appendicitis. If I miss the word peritonitis in that dictation, this is what happens to the MSDRG. It changes, the geometric length of stay changes, and the hospital reimbursement changes. And so appendicitis is also one of the unusual DRGs that actually gives significant weight to the secondary diagnosis. And so many doctors will argue that they're not responsible for treating heart failure since I'm a general surgeon doing appendectomies. And so the reality is that I would beg to differ with all of them, because that's exactly how the hospitals receive their reimbursement and their reputational advantage. And so there's things such as case mix that doctors don't actually know how to talk about. And case mix dramatically can change the way Medicare reimburses the hospital, not just Medicare, but the primary or the private insurance companies as well. I'd like to take just a moment to I skipped over RVU comments, and an RVU is the relative value unit. And so if you look at surgeons, the money that we are reimbursed is based on that. And so this year, Medicare pays about $37.89 per RVU. So if I do a case that has an RVU value of 10, then that's roughly $378. And so just to put that into perspective, the work RVU in Alabama, or actually the work RVU never changes. The other components that I showed earlier does change. But in Alabama, I get paid by Medicare about $677 to take out somebody's gallbladder. A private insurance company, Blue Cross, will pay me about $1,290. And so each state has different reimbursements, but all of it is based on the work RVU. That's what the physician can change by understanding the CPT and ICD process. So another common operation, gallbladder, you can see down at the bottom on the right. If all I said was I did a laparoscopic cholecystectomy for cholecystitis or cholelithiasis, you know, there's what's at risk there. It changes the DRG, it changes the length of stay expectation. And so if you do have the routine gallbladder operation that stays 6 days, you know, that it's fine if it's an outlier. It's not fine if it happens every single time. And so you can see that there's an expectation when you're using MCC codes, which stand for major comorbid conditions. There's an expectation that that patient will consume more resources. And so once again, we're adding order to a disorderly process. So you look at specific documentation requirements. So the procedure that's done for gynecomastia. So that is a procedure that has to be pre-certified. And so to pre-certify this, there's some certain requirements that have to happen before they actually even give us permission to do it. But when we do the procedure, we are expected to include, obviously, the diagnosis, the side, the etiology, the BMI, the procedure, the tissue removed, and the purpose. And so by adding questions into this tool, we're able to have the surgeons answer those up front so that we're not taking to chance the dictation that follows. And so inpatient-only procedures. You know, many people might think that this is something that could never happen. I'm here to tell you it happens all the time. Me personally, about 10 years ago, I took a patient to do an embolectomy of a clotted FemPop graft, and when I got inside, I had to do a thromboendarterectomy, which is literally just removing plaque from the common femoral artery. The problem is that I sent that patient home because I wasn't aware that the endarterectomy was inpatient only. And what followed was letters from the CFO and the coding department that said, you know, you just broke the inpatient only guideline. And so in our tool, what happens is any procedure that a surgeon records that would actually predicate an inpatient stay is labeled at the top. And I'm not aware that if you're dictating a procedure, that can ever happen. And so if that did happen in your hospital, or let me just say this, I'm sure that this happens in hospitals all the time, and we think that using a tool with a rules engine or surgical guidance is the way to stop that. So, Mercedes, next question.
Okay, thanks. Now that we've got you guys warmed up a little bit, let's move on to our other polling question. And just so you know, we're not going to inundate you. We only put in 2 to kind of get you guys interested and to get your feedback. So here's this one. This is what percentage of the time do your surgeons finish their procedure notes immediately? As you know, we've got, and it depends on your hospital system, we've got our brief op note that we need to get done so that when the patient goes to whatever the post-care unit, ICU or post-anesthesia unit, people know exactly what was done, kind of for the critical elements of this. It's not our final op note. And most hospitals require both of them because you can't do a complete good op note in time and move on. Again, this is an elegant solution that will help you get a complete, accurate op note immediately. Could even get rid of the brief op note requirement because you're going to have all the details. So with that, we're interested in how things are at your institution, which have finished their notes immediately. And here we go. We kind of got a variation on this, kind of looks like a bell-shaped curve. So 50% say that you have them done, and the others don't. You have them done 75% of the time in 30 groups, and all of the time. Let me just scroll down. Well, actually, some of you actually have that done, so that's interesting. This solution will have it done immediately and accurately for you. So that's the benefit of that. So let's move on to the next slide. So we've kind of gone through the details and put it together for you, the issues with the surgical documentation. It's a regulatory burden. They're not only the rules around it, but they're also the denial system, which spends a lot of time for the hospital system and also for the providers. There's the lost time burnout, which again is a problem for the providers, but it's also a big problem for institutions. There's a great deal now looking at the cost of replacing a provider that's moved on, physician, nurse practitioner, PA, which is very important. And then there's the lost quality of care because you're not getting the accurate information to all the members of the teams taking care of the patients. So it's a completely suboptimal process, whether it's a dictation, a handwritten note, then transcription later on. And again, Lucian, I think you had some comments on this slide, or Ben, and then I'm going to turn it over to Ben at the next slide to tell us about his experience. But Lucian, did you want to make any comments on this surgical documentation process?
Sure. And, I will say that, one of the problems is and I tell people that with whom I work, is the last 7 words of a dying organization or process is we've never done it that way before. So the process that surgeons have used, since the beginning of surgery has been, go to the phone on the wall after we do a procedure and then vocally, transcribe or talk it out. And hopefully that covers all the bases. But as I mentioned, that's a disorderly process, and surgeons are not trained, as Dr. Diddy mentioned. I will go back to the poll question just a moment and say, I know that you in the audience are wondering how this changes things. Well, in actuality, if we do what the World Health Organization says, which is the timeout process, I'm a big believer in that. And so every single case I do, I prep the document. I look there and say, okay, this is why I'm doing this procedure. This is my planned procedure. This is the patient's allergies. These are their comorbidities. And so I'm lining this up, refreshing in my mind how I'm planning to do this patient surgery. Then the surgery is done. And when I complete that, before I walk out of the room, I have a PC in the operating room proper, and that can be done. Now, there's other ways to finish notes. Not everybody does it that way. Very often there are dictation lounges where we go. But the problem is that the problems that are associated with health information management systems, getting the information, is all across the board. If you have problems with physicians, they typically put sticky notes on that room or 8 by 11 pieces of paper and say, please don't fail to mention this when you do a debridement. And so to me, that's still, it's not getting the job done. So that's why adding an orderly process, having a program that does that is so important. Dr. Diddy?
And just to focus on this slide for a moment before we move on, this process that is delineated at the bottom represents something that is incredibly inefficient. This is what kills the ability for physicians to get through high numbers of cases in a day. It requires duplication of effort. There's no reason that you need to do a brief operative report if you, in the same amount of time, you can complete your procedure note that includes all of the necessary pieces to communicate to the PACU staff and then staff further down the line and get it done in the same amount of time. So that's the nice thing about Vincari, and that's what we'll talk about here when we transition to the next slide. So what problems did I have in mind that I identified that I was trying to address? Well, as I mentioned earlier, I knew that I was well trained as a surgeon. I knew how to describe the procedures that I was doing, but I didn't know what the CPT codes were. I didn't know what specific verbiage I needed to include to make sure that it captured the complexity of the case and to make sure that my practice would be reimbursed appropriately. So I decided that the best way to introduce Vincari to my practice was through my surgery center. I was very busy there doing quite a number of cases there, and I'd spent a lot of time talking with the manager of our surgery center and understood that transcription costs were a big driver of cost in our center. So when she found out about Vincari and the ability to reduce manual transcription costs, she was very intrigued. So I was the first surgeon to introduce Vincari and start using it. I was only using it at the surgery center, was not using it at the hospital. And within a couple of weeks of introducing Vincari, I got out of the operating room and I had an email from our director of compliance for our practice. And just said, will you please give me a call when you can? And I thought, oh goodness, you know, something bad's happened. What's going on here? So I gave her a call back and she said, tell me a little bit about this operative report that I saw from the surgery center. That our coders looked at this, they love it. It includes everything, it captures everything, it suggests CPT codes for us to use. The format's beautiful. This document is ready for billing, and we don't have any questions or queries. And so, I was shocked that it was so warmly received. And they said, well, this is fascinating. We didn't know you were doing this, but we're very interested in this. So the next step was to roll out Vincari for use by all the surgeons at our surgery center in Greensboro, and then the practice introduced it to their surgery center in Charlotte as well. And so it was used for all outpatient surgical cases within both practice locations. What has my experience been like? Well, like I said, I never learned anything about CPT codes during residency, but by documenting with Vincari, going through and answering the questions that were prompted through the artificial intelligence engine, and then reviewing my operative reports at the end, I was able to see which CPT codes were attributed to this procedure or to these procedures, what additional CPT codes were on there that I didn't realize, the fact that using a peak spacer for an anterior cervical discectomy reimburses differently than using allograft. I didn't know that, never learned that in residency, but through using Vincari, I learned that. So where do I find the most value? Well, there's not one place where I find the most value. I would say the greatest value is the time that it has helped me claw back. Like I said, I no longer have to write a brief operative report and then go to the dictation room and dictate much of the same information, but with greater detail. With Vincari, in the same amount of time that before I would have been able to write a brief operative report, now I can go through, respond to prompts, use my templated operative reports, and create a full procedure note in the same amount of time that the brief operative report would have taken. Another instance in which it saves me a lot of time, and I learned this when I compared my experience at the hospital where I wasn't using Vincari with the surgery center where I was that from the surgery center, I never once received a coding query. But there wasn't a week that went by that I didn't have at least 2 or 3 coding queries from the hospital. And a lot of the same types of cases were being done. So it wasn't that the complexity of cases was different. It's just that using Vincari at the surgery center, I was prompted by the artificial intelligence engine to answer any of the questions that would have generated a coding query for my documentation at the hospital. So what are my recommendations? Well, my recommendations are to get this in front of your surgeons. Let them use it, let them try it. I think that once they use it, there's little likelihood that they're going to want to go backwards. It answers so many questions, and it never slowed me down once. I mean, it never interrupted my workflow. It only made me more efficient, and it saved our organization money. It has sped up the time from completion of the procedure to the time that we're ready to bill for the procedure, and prevented a lot of headaches along the way. So what's next? Well, like I said earlier, I'm in the process of transitioning my practice to Florida. I intend to, again, use Vincari at the surgery center there. And my hope in Florida is that I'll be able to introduce it to the hospital systems where I'll be operating as well. I think that clearly we can demonstrate that the value of this system doesn't apply only to physicians, it applies also to health systems because it reduces code inquiries, it reduces or it increases case complexity, and it improves time to billing. So that's my plan to continue using Vincori in the future.
Thanks.
Thank you. We're going to go on to Dr. Newman, and if I can just make one comment in what you said as far as reducing coding queries. Like I said, I work with a clinical documentation improvement program for Nuance, and the advantage we see with this, it will allow these clinical documentation specialists at the organizations to spend their time more wisely. For anybody who has a CDI program, you know that they're running around trying to track docs down, do this, do that, and missing charts. So this will actually help to enhance their activity and not be a project to replace them. This will allow them to really be more efficient and work with them. So thank you, Dr. Newman.
So I often tell stories about this being used, and one of my favorite references is the movie Groundhog Day. I'm sure many of you saw that, where, you know, when you wake up in the morning, everything's the same every time. And so the original name of our project here was Raptor Coding, because I, you know, like the movies Jurassic Park, I like velociraptors, and I reasoned that for a system to be used by surgeons who are typically impatient, it has to be very fast, but furthermore, it needs to remember them. Nobody likes to be anonymous. And so the neat thing about this is it utilizes the machine learning or artificial intelligence. And so every surgeon that uses this, their account looks a little different because it starts bubbling up things that they've done before. And it kind of makes you feel good that when you sign in as a general surgeon that does trauma surgery, it's going to offer you trauma. It's not going to offer you the kind of things that, you know, a non-trauma general surgeon might do. Or if you're a neurosurgeon doing only intracranial work, it's going to bubble up the things that are intracranial, not a spinal procedure. And so I do think that's an important concept, because so many of the other medical software solutions don't include that advantage. So if you look at the ways that Vincori can be utilized, I think the most common way is a desktop, whether that's physically in the operating room or whether it's in a dictation lounge down the hall. And, you know, we don't remove the possibility of dictation. There's many surgeons that are uncomfortable not dictating some component. But over time, what happens is the frequency and the content tends to shrink. And so the reason is because of that that memory that's embedded. And so we obviously have Nuance's Dragon embedded within the system. And so if a surgeon wants to dictate some component of the procedure note, then that is done. And so Dr. Diddy referenced, you know, what it's best for. Well, it's very fast, and the neat thing about this is it can be built to be very, very complicated. Over on the left, you see the navigation, or it can be very simple. And so an ophthalmologist just doing a cataract, there's not a lot of variability there. He just needs to include some specifics about the type of implant he might have used. And so the tool learns the common elements of the procedure and bubbles those up. So the other thing, or the other way that a busy surgeon might actually dictate, just hypothetically, if they left the operating room and forgot, you know, we obviously can use this in a mobile environment as well. And so I think that most people, particularly younger surgeons like Dr. Diddy, they demand things in a technological world. On the other hand, my father, who's a surgeon at age 82, still doing wound care, you know, his demands for technology are not quite as great. And so we have adopted the platform to be able to do things. Now, I'm going to warn you, moving forward, there's just a few final slides on what it looks like and why it functions like it does with the rules engine. I do have a few images of a debridement, because if I mention the word debridement to you in the audience, we could describe that if you take off a hangnail, where you're actually debriding a toenail. If you take off a scab off of a wound where you fell on your bicycle, That's debriding a wound, and obviously there doesn't need to be a complicated CPT code for that. But debridement has two components, incisional and excisional. And so if you do a debridement in a hospital, it is incredibly important to be able to distinguish between excisional and incisional. And very often the words that a surgeon might use are not very specific. And so what you see before you is the rules engine. You see the process of yellow, green, and red. Red means that you have to answer the question. Yellow means that there's more information that might be necessary. And green means you're good. You've got it. And so obviously we encourage people to be all green when they finish. And so this is our version of the Green New Deal, I guess. So, so the pressure ulcers, which is a common procedure that we might debride, this one looks pretty bad. And so this is on the bottom of a foot. And those questions that I've answered just above there actually include the specifics that are necessary. And one of the other features of this tool, when you answer a question in our procedure or diagnosis sections, it actually will start importing that information further down the document. So if you said, how does that work? If you answer the yellow triangle here, then what happens is it's going to pop into the procedure and say, okay, what kind of questions might you have to answer for the coding department to be happy? And you're looking at them. That is an excisional debridement. You got to have sidedness, location, depth, square centimeters, area, tissue type removed, instrumentation, and wound sizes. The wound sizes at the bottom, you see that they're black. They're not absolutely required, but it's something that helps the department distinguish, so that a RAC auditor that would come look at the debridements and decide, have you done a good job documenting, I don't think any of them would have a problem with this document. So the questions you see there, once again, the yellow triangle, those are the questions that we just showed you. And then a green document looks something like this, where I've said it's done on the left side, it's on the foot, it's down to the bone, it's 30 square centimeters, and you can see the tissue types that we removed there. And so not only are we able to embed photographs very easily, you get those on your document immediately. And I know many of you are out there asking, well, you can't have cameras on your cell phone and you can't have cameras in the operating room. The reality is that these photographs that are taken, and they can be taken with our app, they never touch your cell phone. They go immediately into the cloud. This is fully HIPAA compliant, and in my opinion, photographs should be included on almost every surgical document, including cancer staging forms that I often put on there, or including x-rays that I might have used to justify, such as where's the port placed, and did I use ultrasound to place that central line? And so to me, it's very important. So you can see here a very clean wound after I've debrided it with a nice granulation base, which is what surgeons want to see. You guys probably don't want to see that, but that's something that a surgeon would appreciate. And so here on my document that is produced in roughly 90 seconds, I've got the preoperative photograph and the postoperative photograph, not only for the coding department, but for me later on, 1 week, 1 month, 1 year later, I can see what happened. And these documents travel with the procedure document, not just buried in the PACS system somewhere. So anyway, Mercedes, I'll let you wrap this up for us. We appreciate y'all joining today.
Thank you, Lucian. Yeah, and so I just wanted, as you said, we've gone through showing you. We're happy to come and actually demo on site for you guys, or through a WebEx, so you can see how it actually works at your institution. But Benkari has been in practice and existence for quite a long time. There are many users with this. It's shown that, as Dr. Newman suggested, that 90 seconds is the average time to complete a completely accurate, detailed, compliant operative note. Reduction in query, which frees up the CDS's time to be more efficient, look at more charts, look at more areas. Some places only look at CMS. Well, this would allow you to deal with the private payers and all other areas to maximize the utilization of the staff. And as Dr. Diddy mentioned, you're ready to decrease the billing time and can actually drop your bill much faster, which again, if you're looking at the big picture, allows for capture of your reimbursement much faster. And of course, it reduces the transcription costs. It's integrated into the EHR's works, regardless of which EHR you have. The other big aspect, I think, that wasn't mentioned is the actual implementation for this. And everybody who's brought an EHR into their system knows that it's quite a painful process. And a lot of times you're left scratching your head. I need help. I'm not sure how this works. Well, first off, because of the AI functionality, the integration of this, it is very easy to adapt and use. The training time for the end users is very fast. As I said, it's integrated into the EHR, and the clinical support of the software is huge. And this is not a selling point. I'm just impressed as a surgeon that one of these things actually works, and it's not more painful than going to the dentist. So I think this is very user friendly, and that would really enjoy, and certainly as an ROI is definitely worth it. Dr. Newman and Dr. Diddy, I don't know, Dr. Newman, do you have any final points on this? And then we're going to move into the Q&A session, and Dr. Diddy. So Dr. Newman and then Dr. Diddy.
Sure. Final comment. I know many of you are thinking, well, we have other software in our hospital. Does this replace it? And the answer is no. I say that your parent software, where you store your information, is kind of like your closet, and we're a dry cleaner. We're going to clean up the information before it goes back in. We're able to interface and integrate with literally any existing software, including the big ones that are out there today. So we're very proud of our ability to work within those softwares and to address a problem that I consider to be critical in all U.S. hospitals. Dr. Diddy?
Yeah, to add on to what Dr. Newman just said, certainly what I've heard when talking to people in IT at hospitals is that, well, we've already got a medical record that allows surgeons to use templated notes. And this software is so much more than templated notes. I would say that the note templates are about 10% of the total value of this product. It's really the rules engine that prompts you for all of the important points along the way, and there's no other medical record that can replicate that. That's what really sets this apart. It's not just about templated notes.
And there's no loss of productivity of your staff. And the other big aspect that hospitals can use this for, or physicians, is for keeping a record of your operations. So when it comes time from a provider standpoint for keeping your accreditation up, your certification with your boards, it's very easy to produce all this. And from a hospital standpoint, when you're doing re-credentialing for your physicians, you can actually very quickly generate the list of cases to be sure that, you know, they're compliant. So it has many far-reaching areas, and we're only talking about surgeons here today, but this is used widely across many different specialties. And we can get into this later in the Q&A, but from specialties, from hospitalists, pulmonologists, all the way to surgeons. So it's very adaptable. That's the beauty of it. So with that, I'll turn it back over to you, Jeff, for the Q&A. Thank you all very much for being a part of this presentation today and participating in this.
All right, thank you, Dr. Dellum. And again, yes, thank you to all of our presenters today for an excellent presentation. As Dr. Dellum mentioned, it is now time to begin the Q&A portion of the program. So we'd like to invite all of you to ask live questions of our speakers. Just as a reminder, to submit a question, all you have to do is click on the Q&A widget at the bottom of your screen. Again, it may already be open for you and appear on the left side. Please note that your questions will remain anonymous and will not be viewable by other audience members. This kind of question, I think, is posed to all three of you. So, Dr. Dellum, I'm going to send it to you first, and then maybe you guys can go through the line and each provide a little bit of insight. But an audience member had asked, what can you do to help teach coding to surgeons that don't really seem to have a care for doing it?
Thanks. I'll start with that and then turn it over to the other guys. Well, It's true about the coding. What we need is the providers, being the surgeons, to have an understanding of coding ICD-10. But this is what I do on a daily basis for Nuance, is talk to physicians and surgeons about the quality of their documentation. And by appropriately documenting, the coding will follow. So, but the problem is that if they don't do this accurately, appropriately, they miscapture diagnoses, because that's what providers do. They have the supporting documentation for a diagnosis, and then they actually have to write the diagnosis. And then the coding professionals, who are professionals, they're the ones who actually end up coding that goes out. So what we don't want the surgeons to know that for every little nuance they have to have code .xx or .1, or, you know, with the PCS you don't need all the characters. But we want them to understand why they have to accurately code. Dr. Newman will explain to you that this Vincari product, it actually does generate the code. So immediately you get a letter sent, you get all of your coding. So they don't actually have to learn the coding, they have to learn why they have to document, and the appropriate coding will follow. Dr. Newman?
Sure. Well, I guess you'll have to pardon me for being a bit folksy. Being from Alabama, we tell stories, and it's kind of like a parent talking to your child and trying to make them understand why it's better for you. You know, the coding departments and the CFO in your facility can easily look at reports that are generated. A busy neurosurgeon that's doing poor coding may be only half as valuable as somebody doing half as many cases. And so that's all predicated or based on the quality of their documentation. And so, you know, surgeons, we have an ego, obviously. It's a hard job. It's tough to maintain. And, you know, nobody wants to work really hard and not get credit for it. And that's exactly what's happening with the status quo. And that's exactly what the goal of this tool is to make it, to obviate the need for further training and coding. Because as you use this tool, it actually helps you understand what questions you have to answer. So, Ben?
Yeah, so the question that was asked was how do you teach it to your surgeons? And my answer would be that you don't have to teach it, but that it's impossible for them not to learn it. So what I was drawn to Vincari for was to offload any of the coding responsibility, to allow the software to do it all for me so that I would never have to think about it. But by going back and looking at my operative reports after the fact and looking at the charge capture screen and reading, you know, the suggested codes, that taught me a lot about coding. So it wasn't anything that I set out to do, and in fact, I wanted to do everything that I could to avoid learning about it actively. But passively, this has taught me quite a bit. Now for all of the common procedures that I do, I understand that, you know, they're going to generate multiple different codes. I know to look out for them, and if for some reason they're not there, then it prompts me to go back and look, well, maybe I answered a question the wrong way. Maybe I clicked yes when I should have clicked no, or vice versa. So it doesn't require any effort on your part to teach your surgeons coding. Vincari is going to do it, and there's really no way that they won't learn something from it in a passive process.
All right. Another question from the audience members, and again, I think this is, I'm going to start with Dr. Dullum. I'm going to start with you first, and then maybe we can go down the line. The person asked, how are the Vincari templates developed for surgeon usage?
Well, actually, I'm going to turn that over to Dr. Newman because he knows and he will describe it. But essentially, I'll just say before I turn it over to him, I developed a lot of my own templates and did them. And when we had the Epic EHR come in, I gave them to the Epic people and I said, please do this for me because they were my flavor. You know, surgeons, we all like our own. And so that's one way that it's done that I would recommend is when it's being implemented at your site. Vincari, you say, this is what I want in my note. That being said, Dr. Newman will tell you about the many options that are available to use it in their other part. Dr. Newman?
Yeah, so every single document that a physician creates, they have the ability to save it as their own. And once again, some surgeons may dictate their first one and save it as their standard. Other doctors may utilize something that doesn't exist anywhere else that I'm aware of, which is our library. And so we use crowdsourcing of procedural notes where any surgeon can go and look at an anonymous list of 200, 300, 400, 500 different surgeons and how they do procedures. And, very often it's very similar. And you may look at that library and change 10 words and then keep it as your own. And so there's actually multiple ways, but we do not encourage a static template. I disdain static templates. These are all very elastic and very individual. So we encourage each doctor to have their own individual documentation. Dr. Diddy?
Yeah, absolutely. I want to echo what Dr. Newman just said. So there are several options. When I first started using Vincari, I took a few of my most common procedures, 1, 2, 3-level ACDFs, single-level laminectomy, single-level microdiscectomy, and the Vincari staff helped me create baseline templates for each of those procedures with variables that I could go through and click for left or right, or which specific level I was doing, or which specific levels I was doing, and then once you've got that baseline template, you can go through and make edits. If you encounter large osteophytes on the uncovertebral joint that you had to drill down, you can add that in there with a very brief sentence. But the other thing that was very nice were for the procedures that I hadn't created templates for. So, for example, carpal tunnel release. And, I wanted to save some time, so I searched through the other carpal tunnel release templates that people had created and found one that looked very similar to the way I do the procedure. But what I really liked is, this person describes this step in a very elegant way, and, I would have never thought to describe it that way, even though that's how I do it. So now I'm going to incorporate that when I perform this procedure in the future. So I think the library is a very helpful tool for creating templates if templating is your goal.
All right. Probably only have time for one more audience question. So I'm gonna go with this one. And this person is asking, how is a rule-based guidance tool different than dictation, and why is it better?
Dr. Newman, I think that's you.
Sure. Well, that one has so many answers it would take me another hour. But the reality is that I do my demos and say, look, I'm going to give you $1,000 to drive down to the gas station and come back. And when you come back, I'm going to give you $1,000 if you answer this question. And the question is, how many green cars did you pass? Well, you weren't looking for it. So surgeons aren't looking for the kind of things that the HIM professionals and the coding professionals have to have. And so if you don't have a rules engine in front of you when you're documenting your procedure, it doesn't work because, we don't know. If I took out your transverse colon and descending colon, every general surgeon would know I took down the splenic flexor. But if I didn't say I took it down, the coding department won't bill for it. And it has to be specified. Now, surgeons know that intuitively, but the reality is that using the rules engine, it'll show you. If you do that procedure, it'll ask you or it'll pop in front of you, did you do the splenic flexor? And you very quickly, as Dr. Diddy mentioned, using this tool provides ongoing continued medical education. And that is the baseline. Surgeons don't know the answers because none of us have been trained to do this in a manner that the HIM professionals demand. It's not their demand, it's just that's what's required to properly describe the procedure. So that's a short answer.
And Lucian, as you always say, I love this quote from you that surgeons know the answer, we just don't know what the question is.
Exactly.
All right. That is unfortunately all the time that we have for questions today. So I would like to, again, thank all of our speakers, Dr. Newman, Dr. Dalum, Dr. Diddy, for an excellent presentation. I would also like to thank our sponsor, Nuance, for making today's program possible. Finally, thank you to you in the audience for participating today. We hope you'll join us in the future for another Health Leaders webinar. This concludes today's presentation. Thank everybody and have a great day.
Thank you.
Thank you.